Welcome everyone to another VITA Learning webinar. Today we have Mr. Peter Peasy. How are you doing, Peter?
Good morning, Jim. How are you?
Good. Peter's been kind enough. He's going to go over some systematic approach to shade taking, digital and analog. It's a big topic. Peter's well informed on this subject matter, does an excellent job communicating photography and shade taking and the do's and the don'ts and help you out understand when you're taking shade, what to look at. So this will be an excellent webinar for today. Just a couple things here before we get going. Your phone will be on mute, so those of you that are attending, if you look on your screen on the right hand side, there's a panel that pops up from the GoToWebinar module, and there is a question box. Just pop that out and then type in your question. Send us a question. We'll have the Q&A at the end. If it's something that's specific for just that one time, I will interrupt Mr. Peasy and have him discuss the topic, of course. So make sure that you send your questions in via that question box. We are going to record this webinar, so give us a couple of days, but in a couple of days we will actually post it on the VITA North America YouTube channel, and you'll be able to revisit that and watch it at your leisure all over again, because Peter is very compelling and an excellent teacher for our industry. So along with today's recording, you'll also find many other topics that Peter has done over the years. So it's great to visit that VITA North America YouTube channel and just see what's there. So Peter is a worldwide dental educator for technicians, dentists, and auxiliary assistants. He's an owner and manager of Peasy Dental Studio in Staten Island, New York. He has a personal appreciation and expertise on all phases of clinical, laboratory, traditional, digital techniques, color communication, and digital photography. He's a board member at the Association of Master Dental Technicians, teacher and educator in the Master Dental Technician program at New York University, faculty member at NYU School of Dentistry as well. He's a member of the American Academy of Aesthetic Dentistry, which is not an easy feat as a technician to be part of. He's executive board member and fellow of the Northeastern Naphthological Society, editor-in-chief, Inside Dental Technology, and in 2018, he achieved the ACP Technician of the Year Award. So with that said, Mr. Peasy, I will turn it over to you as the presenter. And now we should be able to see your screen.
Got it?
And I do have it, so I will bow out and turn it completely over to you.
Okay, well, thank you, Jim. As always, I appreciate it. And good morning, afternoon, everybody, depending on where you are. And this is another Jim title, a systematic approach to shade taking. So I throw you under the bus, Jim. And it's always fun to kind of backfill what Jim has envisioned me doing. So as usual, for every one of these webinars that we have, I'm in New York in my office, working away under a lot of case pressure today, trying to keep things rolling and smooth and the usual stuff. But I think all in all, I can't complain. Things are good and we're very busy and things are okay. Just a matter of managing through them sometimes. So this topic, a systematic approach to shade taking, made me kind of break this down into two real ways that I think I'd have to look at it. One is, first is documentation. And I'm not going to turn this into a photography webinar, because I think I've done a lot of photography webinars, and I feel like I talk about photography so much, but it is such obviously an important part of what we do. So the documentation part is key, and I'll very, very briefly just touch on a little tiny bit of it, but not much. The second part, which I think is the more challenging part, is an understanding. And really, I know that word is so vague, what understanding is, but realistically, just look at the teeth that you see on your screen right now. And if I asked you to describe what you saw, how would you transmit that information? How much information can you give me on the difference between the 26 as compared to the 24? And how do you communicate that with your clinical partner or the patient for that matter about the good, bad, what you see, what you don't see, how do you incorporate it? So there's a lot there. And I think one of the frustrations that I find with shade taking is that we really just don't have a good enough understanding of what we see. And then the second part of that understanding becomes how much space do we have to work in to restore what we actually see? And that becomes more about the material options. So first, photography. For me, it's number one, how you take the pictures, what pictures you use, how you utilize them. I think the famous saying is you can't treat what you don't see. So if I don't have the ability to see it, and I kind of laugh when I think back on, years ago when people used to see a patient, write down stuff on a piece of paper, and then the patient would leave, and then they'd spend the next week or two working on it based on their notes. And I'm thinking, I don't know how we got so close to what we did then, because I know I have a pretty accurate photo of it, and I still struggle to find all the things that I want. So I think the key for us is the photography. And I think I've said before that not only is the photography important for color communication, but there's a lot of good that comes with that. I use it for treatment planning, interdisciplinary communication amongst the team that I work with, a monitoring process. I love it more for that than anything is looking back on my cases and realizing how bad I was when some of them and things that I wanted to improve on. And then I think also today for legal, I like to have a record of all the things I've done. I can't tell you how many cases I do that I did an upper arch, 5-6 years ago, and now I'm doing a lower arch, and I have the documentation of everything I did. And obviously, if there's ever an issue or a problem, having that documentation is important. And then obviously marketing, which everybody kind of really is their focus. But my focus is, what do we see when we look at nature? And understanding that aspect of the chromas and the values and the translucencies and the halos and mamelons and the surface texture and the luster and all the things that kind of fit in there become really important for us to start communicating or be better communicators in the shade taking process. So first off, quick photo sequence. For me, everything starts here, and I think you've heard me say it before. Picture of the face, the dental facial or the white stuff that we want to see, and then the dental or the pink, right? So I've always broken that down, face, white, pink. If you want to sound more educated, it's facial, facial, and dental. And those are where I start with all my diagnostic photos. And then, as I've showed before, I have a diagnostic photo series that's very critical for basic communication. These are not for color communication. These are just basic photo series to see the patient's face, their big smile, their Duchenne smile, how high their lip goes, what they look like when we retract them, where the incisal edge position is when they make that high smile and maybe tilt their head down. And then when I look at the dental facial, how the lips surround, how much display they have, and tooth positions. And I want to know all those things before I get started, just as reference for my communication. After that, it becomes more about physically seeing that in the face and understanding what we like and what we don't like. This is obviously a young man. I think he was only about 17 or 18 at the time. And he has teeth that kind of looks like, or make him look like he's 15 years old, and maybe he doesn't want to feel 15 anymore. So orthodontically would have probably been the best approach for some of this, but even with the orthodontics, it wouldn't have given us all the restoring factors that we need to do what we wanted to do for him. So in the end, we do what we normally do. We're going to do a diagnostic wax up to evaluate the position of the teeth. That's going to be transferred to the patient's mouth via a matrices or an index. And then we're going to start restoring what we like and what we look at in the patient's face as being better for us to understand what's right and wrong. And I think you can see right away as the patient starts talking and speaking, just with that little matrix in his mouth, already he feels better. And by the way, he looks older and more mature, right? But it's basically the same kid with a little bit of a different haircut. So those teeth in the face really mean a lot and really help us to make the patient feel comfortable. After that, we're going to do our normal restorative process, an ABT technique, prepping through the teeth. We didn't do any ortho on him just because we really didn't need it. And then we have to figure out what we want as far as color-wise. Do we want to match the adjacent teeth? What are the prep shades like? Are they going to influence us in the colorations that we choose? And what is the desired shade? Does the patient really want OM1, or do they want 1M1, or they want to blend in and harmonize with where they have? So we need to kind of didactically break our way down through those three processes. In the end, we made him 4 veneers, fairly minimally invasive. We'll place those in the patient's mouth. Obviously, I did these as a refractory cast, which is kind of my, I think, most used veneer technique, although we do mill a lot of them today. And then we'll place that in the patient's mouth, and you'll see a big difference in his smile. So we were kind of lucky in the sense that we were doing 4 teeth. Because we're doing 4 teeth, it kind of allows us to not worry so critically about matching the other teeth. Really what we're kind of worried about is harmonizing in the face and the others, and with the other teeth. But with other restorations, with single tooth restorations, or maybe 2 teeth, and sometimes even 4, really having reference points to figure out what color we want to make those teeth is critical for us. So I'm going to kind of throw out this concept that shade guides, although we use them every day, aren't the most accurate tools for us to kind of work through our process with. And I think where it becomes challenging for me is, obviously I use shade guides and I like certain shade guides, but I want to be clear. A shade guide is nothing more than a reference to me for either hue, value, or chroma. That's really what the shade guide does. It gives me a reference. I'm sure you've heard me say over the years, over in lectures, and for those of you who have paid attention before, that when a doctor asks us to match a shade guide exactly, my argument would normally be that they don't really understand what shade looks like, because there is no such thing as a shade guide that has a perfect match to a tooth. It may have a similar value, it may have a similar brightness or a similar hue, but never would you find a shade guide that matches a single tooth perfectly. It just doesn't exist. So that shade guide for us becomes a reference point. And let's be clear, there's a lot of shade guides out there to use. I tend to work more with one. I'm in the linear 3D guide, and I'll break that one down for you. But all of them are really just references. So what I try to do in the shade taking system is really come up with a way that simplifies what I do, how my doctors work with it, and how we can kind of utilize that system every day easily. One of the flaws that we're doing with the shade guides is when we are taking photography, and I think you've heard me say before, iPhones are not photography. We need a good quality camera system to take the pictures. But the other challenge is, if you don't take the photos the right way, then your reference of a shade guide isn't really that helpful to you either. So having patients in the chair, having the wrong angulations, if that reference of where the shade guide tab or where the shade tab is next to the patient's tooth is not photographed with the right equipment, the right lighting, and the right angle, it kind of becomes useless to us. It's not really much of a reference anymore. And just as an example, I've showed before, this is a patient laying back in the chair, the way you just saw in that previous picture, like that. And you'll notice the doctor's doing what they think is right, putting the shade tab up inside the ledge to inside the ledge, taking their photos. Well, this is the same patient out of the chair, sitting up in my office with the exact same camera. And I want you to compare the difference in the 2 images when you look at them. Look at the number 8 specifically, and look at the coloration that you see and the translucency that you see on the right side of your screen when the angulation is proper and the camera lighting is set proper. And look at that same tooth on the left side of your screen, right? I'd almost argue, because of the angulation, maybe a B shade tab should have been used there, because I see more of a yellowish hue in that tooth, but it's really because of the angle and the way the light is being reflected to it. So really critical is how you take those shades, or how you photograph that information. But let's remember, it's a reference. What is it a reference to? The reference that a shade guide really does for us is it gives us the basics of nature, and how I break nature down is the same way over the years. The cervical area is where you always have the highest amount of chroma. The middle third of the tooth is where you get the most value in your tooth, and the incisal edge is where you'll see the most either translucency or effect or mamelons or secondary dentin, and all of that is depending on the age related to that tooth. So the standard for me is the chroma and the value. The incisal edge is really about the effect I'm looking to apply for that particular patient's age or the aesthetic parameters that you're looking for. The good news about this is the system that I kind of use to look at color is very prominent in how I also see nature. And I think it's something that if you really look at the facial plane of that central, you'll notice right away that there are 3 planes. There's a cervical plane, which is where I always say is you see the most chroma. There's that middle third plane, which is where you're going to get the most value in your tooth, and that has a lot to do with the light reflection. And then there's that incisal plane, or that incisal third, which is a little bit of a crapshoot, right? It's a little bit about how much we want to make the tooth younger or older, or mamelons or not. So that's kind of the only question mark that I think we can determine on our own for what we're trying to create in that patient's restorative. When I analyze color and I look at teeth like this, I think it's very easy for you to say, or even this kind of a picture, is there one shade guide that would match any of those teeth? And which one would you pick? Would you pick B3, A2 for the teeth on the left? Would you pick OM1 or 1M1 for the teeth on the right? And the question is, none of them are really right, because realistically, those teeth have a lot more to it than what we're seeing. So I would want to break those down the same way. What is the cervical color that I'm working in? Where is the mid-third value of those teeth? And what effect am I looking for on the incisal edge? I know it sounds old school, but it's the way we've been breaking teeth down forever, but it's the right way. It's the right way to understand the zones that you're working in and how to think them through when you're trying to communicate the color factor, because there is no one shade guide that would match that. The universal shade guide, I think that everybody kind of goes to here, I always joked over the years, is the D3. And that's the shade guide that I always say that we use when nobody really understands what color it really is. They just kind of go to that D shade. So it's a D2 or a D3. Usually not. And I would argue that the shade D3 doesn't even really exist. I feel the same way about the C shades. I'm sure you've heard me say that before. The reason for that is because of how we see color. And what I mean by that is the world of color, or the color space that we work in, is a vast amount of colors and saturations. But if you kind of look up in that little top corner, that little circle that you see there in color, that is dental color. That little space that's up in the upper right-hand corner there, that's where all the dental color exists from. And if you actually analyze that a little closer, you'll start to notice that in truth, the colors that we use in the classic guide, the standard A, B, C, and D shades, do not really fit very well into that little color space that makes up nature. You'll notice that there is some A and some B colors in there, but notice I put the B1 at the outside edge of that little circle. And the reason I've done that is because the B1 does not really fall into tooth color as we know it, neither do the C and the D. And that's why I say they do not exist in nature. So most of the shades that you work through fall in the A range, A1 to A4, and in the B range, B2 to B4. Those are where the most colors of teeth come from that we usually utilize when we're restoring teeth. Does that mean that I never use a C or a D shade? No, I do, but I don't use it probably the way you use it. I use it more to absorb or reflect light, manipulate the light effect of my restorative, rather than just use it as a specific shade. Also, the interesting fact there is the B1 that is sitting outside that shade guide. Just so you know, from statistics, it is the most remade shade in the country, B1. So it's the one that people used to pick the most years ago, before all the bleaching craze hit. It was also the one that was remade the most because it never looked as natural. Twofold, technician-wise, maybe we didn't support our B1's value as well as we should have. And then aesthetics-wise, it never really blended or harmonized as well with the face because of the fact that it didn't really fit into the tooth color world. So When I say you need to understand what you're looking at, let's kind of break down those three keys again. For one, we start with the cervical. And what you should always notice on the cervical of your tooth is where you see the most chroma, the most influence of pink from healthy gingival tissue, and usually a certain amount of translucency there. So that's the first part that I want to communicate. Now, I do also know, especially with some of the doctors I work with today, I hear all the time, patients don't want any color, they don't want any orange or yellow, and I get it, and we have to try to stay away from some of those. At the same time, they do need something. They need something that's going to be there to add a little warmth and a little more translucency, so it creates depth and it doesn't look exactly the same as the middle third of the tooth. The middle third of the tooth is where the value has to raise. And if we raise the value properly, then that cervical third should have a little lower in value or a little bit more chroma or more light absorption. I think it's really important that we really break those two definitions down. Without that, you get a very monochromatic looking and a very fake looking tooth. If your patient wants fake, fine, make it all in one white bright shade. But if they want them to look bright and real and natural, you need to vary those colorations. And then lastly, like I said before, that incisal edge. And again, for me, that's really more about what are the effects that I'm looking for, what are the age of the teeth. If you look at these incisal edges, they're beautiful. Would I put them on an 85-year-old patient? Probably not. At the same time, would I want to make an 85-year-old incisal edge for a 40-year-old patient? No. I want to vary that according to what we're trying to achieve in the patient. And that's why I kind of like let that one float a little bit more. Also, as we age, you'll notice that the teeth start to wear down. They either chip or break down, and you tend to lose some of that translucency and some of those embrasure spaces. So because of that, the coloration that you see in the incisal edge is a little bit different. And again, we have to take that into account as we're working our way through. The other area that I look for in the tooth itself is the harmony of the pink around it. And one of the other challenges we have is that things that are larger or closer to us appear brighter. So what I mean by that is if I'm looking at the number 8 or the number 9, the number 8 looks so much whiter and brighter, but realistically, it's not that much different in color, maybe a hair brighter, but realistically, it's because of its size, because it appears so much bigger and longer, and that makes it appear much brighter. So we have to be very aware of that in the sense that if we want the two teeth to really match, maybe it's not really just about matching the color, it's about matching the gingival harmony. And I really would suggest to this particular patient crown lengthening. I'd want to make the tooth the same length as the adjacent tooth and then try to get the value in a similar ballpark. Okay, so that's kind of the way I work through that all the time. Now, I said everything we do starts with the face, what we look at. And when I look at the face, you can see a happy-go-lucky patient. She's missing a tooth number 10, and she wants to replace that. I'm going to tell you that it's going to be an implant. But before I start, I'm going to kind of reverse how you take your shades. I know when I ask the question how people take shades, all the hands go up and everybody has a way they do it. The number one answer I hear all the time is value. I pick the value first. I want to know what the value of the tooth is. The value is the most important. It seems like that's kind of drummed in our head. Well, maybe you're right. The problem for me with that statement is, though, you can't really pick value without understanding enamel. And enamel is really what is the window into your tooth and what allows you to see what the value truly is. But before you can make that determination, your first point of reference is what is the enamel that you're working with. When I'm using a more of a milky type enamel, and by the way, the three that you see here on my screen are the three types of enamels that exist in nature: milky, translucent, and transparent. Those are the three types of enamel that our bodies make. Which one your patient have is for you to determine. If the enamel is more milky, that means it reflects more of the light from the surface, and you don't see as much inside the tooth as you would with a translucent enamel, which means more light goes through the enamel and you see more of the coloration of the dentins and the effects inside the tooth. And then the last one would be transparent. And this you tend to see much more in older teeth, where as we age, the enamel demineralizes, becomes much more translucent, and you're really getting a much more glossy kind of a tooth from a light perspective point of view, but also getting much more of the coloration that you see inside a tooth. So that's really what I'm looking at when I'm starting to look at my teeth. What is the enamel that I'm working with? And I'm trying to look at this patient's teeth and say, okay, I need to replace this. It's going to be an implant that's complicated enough to put one implant amongst all the natural teeth. But really what I have to figure out is, how am I going to finish the tooth, right? Because most of us are already starting to think about, what abutment do I use? What material should I use? What shape is that lateral going to be? I'm actually kind of going the opposite way, and I'm looking at the contralateral side, and I'm looking at the surface topography, what enamel is really on that tooth, and is it milky, translucent, or transparent? What enamel do I have to work with? And once I know that, now I can start looking at the reference points for what I want to do to pick the actual tooth color, because that enamel choice is going to affect how I see the tooth. So I'll kind of walk you through this case a little quickly. I just showed this case the other day, so it was on my mind, so I threw it in here today. You can see there's a lot of surface topography, but you should also see that that enamel is somewhat of a translucent type enamel. That means that I can see some of what's behind that tooth. So just to pick the value based on what I see on the facial surface isn't enough. I want to pick what I see from behind it, which means I know I have to finish this tooth with a more translucent covering to make it work. We'll go through all our normal shade systems, and I'm going to walk you through how I do this, and I'm going to tell you what you're seeing in this picture is 100% wrong. If your doctors are doing it, tell them not to do it. I don't want my shade tabs put in over a tooth or put in edentulous areas for several reasons. One, the eye sees color better in horizontal lines, and the minute you take your shade tab and put it over another tooth or in a space, you're actually shadowing the teeth behind it, and you're changing the scope of what you see in that color. So I don't really want to do that. So that's kind of a negative. What I really want is my shade tabs edge to edge, and usually contralateral. So in this case, the patient doesn't have a contralateral. They actually only have a cuspid there. So it's not going to be very helpful to us, but I still want to get a reference to what that coloration is on the other side. And then I would come back and utilize the central, the number 9. I might even utilize the cuspid as an in-between, and a little bit on the lower teeth. This implant was done. It was actually an interesting case because we made the abutment, we made our implant verification jig, right? So that the doctor can put that from the model straight to the mouth and verify that the abutment position is correct. We made our plunger to make sure that we're not putting too much cement in the implants, all the things that we would normally do. And everything worked out pretty well from what I thought. Only challenge was is after we made the abutment, we realized that the patient actually lost some tissue that they had. You can kind of see that if you look at the left of your screen. You can see where my marginal finish line is. It's up and above the tissue. And if you look at the right of your screen, you'll notice I can actually see the marginal finish line where the finish line actually is. So that's kind of a problem for us. And unfortunately, I'm going to have to go back and rework that whole margin, that whole abutment and the whole crown. So that was a little challenging, but okay, it happens. The tissue changed, so I'll just come back and I'll drop that margin down to the right spot. I'll remade the crown. I remade the jig for the cement jig to get rid of all the extra cement, and we remade the crown. And when I did that, what I want you to notice is that all the information that I started with is what the information I finished with. What was the enamel layer that I needed? And how did I make the value behind it work for me, being that I needed to have a certain amount of translucency and a certain amount of white frosting that floated over that tooth. And that to me is really a determining factor of how we're going to make that tooth match, is to understand what that translucent layer is. So as far as the shade guides go, I told you that I do tend to work with one. I'm a fan of the linear 3D system. I'm not a fan of the classic, even though I do talk A and B sometimes. And the reason I'm not a fan of the classic is I just feel like there's a few issues with it, besides for the fact that I don't believe the C's and D's exist, and I don't really like a B1 as a shade reference either. There's a few other challenges that I find with the actual classic shade guide. One of it is this. when those shade guides were designed, the way they were designed was on a chroma to translucency scale. And what that really means is, if I start at the cervical, I have chroma. When I start to move down the cervical, I have less chroma. When I move down to the middle third, I have less chroma. When I move down towards the incisal third, I have less chroma. And then when I get to the incisal edge, I have translucency. So it's a chroma scale that shifts the chroma down to a translucent point. That's not what teeth really do. Teeth have the chroma in only that cervical third, and then the value starts to change. And I think I showed you that in my first few slides. One, it changes because that's where the brightest part of the tooth is, but it also changes because of the three planes and the angulations of the teeth and how the light reflects from the teeth. So this is why I say the old shade guide is a little bit off for me as a real reference, and I tend to want to stay in the 3D system more often. Now, the 3D system is a lot more simple system to use, and I think most people are aware of. First off, just so you're clear, the basic guide that you're using has a gray base to it, and that gray is an 18% gray. And the reason it's 18% gray is because the retina, which is a muscle, loses the ability to see color very quickly, 10 to 15 seconds. And if I just look at something 18% gray, it relaxes the muscle. It's kind of like the refresher for the muscle. So realistically, when you're using your shade guide, you're supposed to look at your shade tabs and drop your eyes down to the base of the guide. So it kind of relaxes the muscle, and then it allows you to see the color a little bit better. I'm a fan of the linear system more than this 3D master system. And really, the only reason for that is, even though the system is very similar, is the one on your left is just kind of messy to me, right? There's a lot of shades and they're kind of sticking out all over the place, and it kind of doesn't give you the formula for how to work through the process. So in the linear system, the formula is a little bit better. And what I mean by that is the first guide that I'm taking is really my value guide. Now, be clear, when I'm choosing my value, which I said is not really the right way to start, I'm choosing it based on the first thought of what is the enamel that I'm working with? Is it transparent? Is it milky? Is it translucent? Once I know that what that is, then I go back and look for the basic value of the tooth. And the reason that I'm doing that is because sometimes when I have a very translucent enamel, it means that the value that I see inside might not be the appropriate shade to use. An example for that. You see an A1 with very translucent surface. Well, if I actually built the case with A1 dentin and very translucent surface, what would happen? I wouldn't have A1 at the end. I'd have a lower value, or maybe a C shade. Why? Because I have too much light passing through the enamel and hitting my A1 dentin. So my point is, the value that I'm picking is really based on that translucent level, and that allows me to say, okay, maybe I need to go to a bleach shade or something a little whiter or brighter to give me more light reflection. This way, when I cover it with translucency, I'll have the value that I'm looking for. After I pick value, I'm going to chroma. And I think the beauty of the system is how simple it works. So step one is I'm looking for my base value. Step two is, what is the chroma that I'm working with? And just to be clear with everybody on this shade system process, you have L's and R's. What do the L's mean? The L's mean really light, or I would argue yellow. Anytime I'm incorporating more lightness or more yellow into your shade tab, it means that you're getting a higher looking value because you're getting more light reflection. The word R, or the letter R, really stands for red. And every time I'm incorporating more red into the ceramic, I'm lowering the value of the ceramic. So I'm actually getting more light absorption and lowering the basic value. So the simplicity of the system is, one, what is my basic value of the tooth? And now that I know what that is it more in the yellow or more in the red family? So it's kind of a very basic and simple system. And that's what we tend to use with most of my doctors today. It really works a lot better. And again, it's only a reference point, right? I'm just using it for reference to help me determine. So like I said, where does it start? First, what is the enamel that I'm looking for? Two, what is inside or underneath that enamel that I need to support the final coloration? Remember when I talked about ceramics over a period of time, we always talked about that no matter what the restoration is, I need to finish that restoration in about 0.2 to 0.5 tenths of a millimeter of enamel. And again, that becomes more critical now in my shade taking, because whatever that enamel is, it's going to help me determine what I need to put on the inside or underneath that enamel to support it. And also the thickness of your restoration plays a role in that. If you're doing very minimally invasive restorations where you're just maybe doing a very thin shell over the tooth, well, you better choose something that's fairly translucent if you have the color behind it to support it. If I don't, if I have a darker prep shade, maybe I need to go with a lighter type translucent material to help mask some of that prep shade. But the more space I have, the more theoretically we can go back to our 2 to 5 tenths of a millimeter of space. And I'm always thinking about this through light optics. How much light goes through the material that I'm using? So if I'm using a clear material, almost all the light is going right through it, or my very transparent enamel. The more the enamel becomes more opacified, a whiter type enamel as an example, the more reflection I'm getting from that enamel. And the dentins and what's behind them aren't as critical. They're still critical, but not as critical because I'm getting more reflection from the surface. So it's really important that, again, when you're choosing that first point of what type of enamel do I have, that's what's going to determine where I need to bring my dentins and what are the materials I'm going to use as I do that. Like I said to you before, to me, it's all really about light. So I'm really trying to manage the light process. Okay. Also, I do want to manage the transition. So I said to you before that I have more chroma in the cervical third, value in the middle third, and whatever that incisal third is going to be. And I tend to build teeth the same way. So I'd always start by trying to create some chroma. I try to pick up that value in the middle third. And then the incisal edge and effect that I'm going to make is going to be based on the age of the patient. But realistically, before I did any of that, my first thought was, what type of enamel should cover that? And notice my shell of enamel over those teeth right now. It's kind of a fairly transparent enamel. So what am I trying to do? I'm trying to allow a lot of light into the tooth and have my dentin, the mamelons, and structure carry the coloration. So let me kind of play that photo for you again so you really get the idea. I have chroma in the mid third. I have value, I have chroma in the cervical third. I have value in that middle third area, and then I have my mamelons in effect around the incisal third. My shell, or my veneer, as you might want to consider it, or filtration system, as we've done in other webinars before, is going to be fairly transparent. So that means when those two kind of come together, this is the effect that I'm looking to create. Chroma, value, age. Those are the three things that I get by figuring out which enamel that I wanted to use. So the brightness that you're seeing in that middle third isn't necessarily from the enamel, it's from what's behind it. And that's why when you pick your value first, you're kind of making a mistake without understanding that translucency that you want. The best example of this was a friend of mine who did this years ago, my friend Adam, and I love using this example. So I want you to look at the colorations you see here on these pencils. And if I really need to use what I said, something very translucent, I want you to watch what happens as the translucency gets thicker from 2 tenths to 4 tenths to 6 tenths and so forth. So this is my translucency or transparency. And look what happens here. Notice all the way to your right, at 2 tenths of a millimeter, you kind of get a little bit of a lower value, but you can see all the colors coming through. And as that enamel gets a little thicker, as I go to 4 tenths, I'm starting to lose the ability to see some of the colors, but also the gray factor, or the value is dropping even more. And when I get to 6 tenths or 8 tenths, you can see that it becomes just a gray wall, right? It kind of just, all the light dies and doesn't really get through the surface. If I switch that concept and I do the exact same thing with a whiter type of enamel, I'm going to get the same or the opposite effect. At 2 tenths of a millimeter, I can see through, oops, sorry, why did that go so fast? At 2 tenths of a millimeter, there it is. At 2 tenths of a millimeter, you'll notice that I can still see the colors through. The minute I go to 4 tenths, you see I'm not seeing much color coming through, or very little. And by 6 tenths, almost none. So picture that in your enamel choice. If I have a very milky enamel, that surface that I have is not really allowing me to see much of what's behind there. Whereas when I have the translucency, I'm getting what I see in the backside or the inside aspect of the tooth. So think of that little photo, I think, when you're kind of trying to pick your shades next time. What is my enamel that I'm working through, and what is the value? I've already said to you the shade guide should be edge to edge, not overlapping the teeth. And I think this is most challenging for us when we're doing single tooth restorations, right? So this patient has most of all their natural teeth. I have a little chip on the number 10 there, but I have to match that one tooth, and that's kind of the biggest challenge. And this is where it's important for us to really walk through that shade taking process. So I'm taking the contralateral side. I want to see the coloration of the number 10 for me to work through my number 7. I also want to see what the prep shade is, so I know if that's going to influence what I'm working on. I'd also like to photograph not only the adjacent central and cuspid, possibly even the lower, and I would also like to do that under polarized, so I can kind of get a different effect of what I'm seeing inside that tooth. And then we'll fabricate our final restoration, and hopefully we can make that kind of blend and harmonize with what the patient has. Pretty close. I wouldn't say it's perfect, but okay, close enough. And then you'll notice on the polarized, it actually looks a hair brighter under the polarized, but again, pretty close. I don't know if it was cemented at this point. So this is where it's really more challenging, right? Is the, oh, no break. This is where it's more challenging, is where we're trying to match one tooth. Single centrals, I've showed this case before. Same scenario here when I'm trying to match one tooth to all the other teeth in the patient's mouth. I have to look at everything, the face, the white, the pink, the gingival harmony. In this case, I think I've said before, I actually thought that maybe it would have been smart to do a window veneer on the number 8, only because the space was so big on the number 9. But in the end, we decided not to. So we're going to try to make that bigger space look smaller by creating the right contour and shape and surface of the tooth. I start with my value photo, just like I said before. So I'm looking at the number 8 as my reference and finding where the value is for that tooth. But I'm also looking at the translucency, and you can see that that tooth has a lot of translucency on it. So in order for me to get to that translucency, that's why you see an OM3 guide in there. It doesn't really look as bright as an OM3, does it? But yet it's very translucent. So I know I'm going to have to probably utilize OM2s and OM3 to get that value right behind my translucency. I can confirm value by using a black and white photograph or just changing that in your camera settings. But again, you should notice that, look at the OM3 tab, that should look a little high in value to you. Yet at the same time, when you look at it in the black and white, it doesn't look that far off. It actually looks like it blends a little bit better. So that's kind of another way to really help determine the value that you're seeing. After I take all my shade guides, I tend to always use the Easy Shade. The Easy Shade, I think, is a great tool. It's really a densitometer, and it kind of gives me a specific point, and it gives me a measurement of the color scope that it actually reads. And I have to say, it's really pretty accurate. I know some people use it as their shade-taking device solely. For me personally, I use it to test myself. So I actually like to take all the shades first, come up with my conclusion, and then take my Easy Shade. And if the Easy Shade confirms what I thought, I feel smart for the day, and it's great. If it doesn't, I usually think I made a mistake, and I have to go back and reevaluate and kind of make sure that I didn't miss something. So I'm using it more as a testing tool for myself. And by the way, I could also use it to photograph my restoration at the end and see if I get a very similar measurement. And if I do, it makes me feel a lot more confident. So I do use the Easy Shade a lot. There are also some other tools that I'm going to kind of touch on a little bit. I have to speed up so we don't run out of time here. Obviously, I'm using polarized almost all the time, especially for single or 2 teeth, because the polarized filter is actually giving me the ability to see more inside the tooth. And I think when you look at the tooth this way, you can see the white frosting is more on the surface. You can see that there's a little bit of a band of a white enamel that kind of flows through there. And you can see the opacity that's kind of in that center third of the tooth that I would want to really try to do in my build-up on my restorative process. So the polarized really helps me there. Okay. Now, unlike the original photos that I showed you, which were just basic diagnostic tools, as I get into more specifics, I need to be much more clear and a lot more photos taken to match a single tooth. First step, number one, is you're never taking the photos when the patient has been anesthetized or they're sitting in the chair too long. You want those photos to be taken as soon as early in the appointment as possible. And that's just because that the longer the patient sits there, the more with their mouth open, the more dehydrated they get. And the minute the patient's anesthetized, that slows the blood supply down to the tooth, and the patient also becomes very dehydrated. So you want to make sure you're managing the time that you're doing that. We follow the steps that I said. I already know I need a very translucent outer side. So my first step now is to find the value that will support that translucency underneath. And I can tell you I'm leaning way towards the OM3 here, maybe even a little OM2 in some areas. I'll confirm that value, and then I'll start to look at the chroma. Is the chroma more in the OM family, or is it really more in the 1M family? And I'm going to tell you, for me, the chroma is going to go into the 1s and the 2s. So I'm going to use probably a 1M2 or 1M1 in combination with some OM2 or OM3 to find out where I think that coloration is and where the warmth is that I need. Again, photos are taken both ways, polarized and not. I'm going to build up the restoration. We'll put it in the patient's mouth, and it kind of worked out okay. For those of you who saw this restoration before, I think you know why I dislike it so much. Although we kind of hit all the values and the shape and all the good things that we needed, the one thing I missed was the surface typography. And I didn't really miss it. I think I put it in there. I think I polished it a little too quickly and lost a lot of it. So the one flaw with this single central is surface typography is off. And that's enough to ruin the single central for me. But from a color and value standpoint, it had everything that I wanted to. Look at the chroma or the warmth in the cervical third, look at the value in the middle third, and then you look at the effects on the incisal as I get towards the incisal third. And you'll see that we kind of hit all those right. And not only did it confirm on the polarized, but it also confirmed when I shot it with my easy shade. So I kind of had the best of both worlds, and I can evaluate how close I was before I sent that case back. Another thing that I'm using a lot today, and I'm not perfect with it yet, I think there's still a learning curve for both the system and for me, is something called OptiShade. And OptiShade is really just a fancy polarized camera, let's say, just a single camera that takes a picture of a single tooth with a polarized filter, and you're allowed to actually put that photograph into a program. So I use my iPhone, and it goes right into my iPhone, and I can actually transfer that information that I see in my polarized filter to a computer screen or a computer program. And what that computer program does is it allows me to move the cursor around the tooth and create formulas for every area of the tooth that I'm working in. So it'll give me what I see in the cervical third, it'll give me what I see in the middle third and the incisal edge. And it is quite complex, I must say, because it can give you so much detailed information. But so far, I think I've done about 4 or 5 cases with it. I have to say that I think I'm about an 80 percentile with it, that when I've used it, it's almost been perfect or pretty close. Once or twice, I was way off in left field, and I'm not sure if my formulation was off, or I built it off, or maybe I just didn't understand it well enough yet. But the more and more I use it, the more I'm starting to feel like this is a very valuable tool for us, and I'm getting more and more comfortable with this process, and I'm actually using it more and more, not just for single teeth, just because I really like to have a better understanding of what I'm doing with my ceramics. It's very interesting. The one thing I'll point out is I tend to think, especially when I'm in the 1M1s and the OM shades, I tend to think that when we get into those brighter colors that we need to get a little bit more of a peachy color in there. So a lot of times in BN9, as an example, I'm throwing in 5% of EC7 or EE8 or both of them sometimes. Why? Because I'm putting a dot of peach into that color, or salmon color, to kind of create a little more warmth in the brightness. What's really funny is that I started working through the OptiShade system, almost every formulation that it comes up with, I notice it has the same process in there. It already has an EE7 or an EE8, or it's asking for a pink or a salmon color stain. And it actually makes me feel good because I feel like it's something that I've been doing for a long time. And the fact that it's reading those details, I think, is the sign for me that it's going to be a home run process down the road. Although I honestly say I don't know if I'm perfect with it yet. I'm still working my way through it and trying to understand the whole concept. But in the end, now my job is to understand what that surface is, where the value is that I'm working through, and then how I'm going to build that concept into the tooth to make it work. And normally what's happening is when I want to finish with some sort of a translucent enamel, like I said before, I'm going to have to really raise that value inside. And I'm going to raise that value by probably bringing up the value of the dentins that I'm using. You know, a simple way to think of this is when you're working in lithium disilicate, the doctor asks you for an A1 shade. How often do you actually pick the A1 ingot? And I hope your answer is never. You should almost always be choosing an ingot of higher value, B1, BL3, whatever system you're using. Well, it's the same here. When I'm looking at the cases and I want to achieve that A1 or that 1M1, right away my brain goes to, I need to bump up that value internally. I have to get something brighter to start with because I'm going to lose it when I start to filter that out with my enamel systems. And if we can create that very translucent looking effect and still get the color and value we want, I think that's where teeth look the most natural case, most natural for us. This is a veneer case from a bunch of years ago, but I'm not usually happy with many of my cases, but I do like how natural these teeth look. And I think it's really just because of what I said, that translucency, that surface topography, and then supporting the value and the color and the chroma from the inside. And that's really what makes it work. Unfortunately, I never got to do the lowers, although I wish I would have, because it would have looked so much better, but you get the idea. Okay, so I'll walk you through one last case and then we'll stop for some questions. I'll go through this quickly because I think you already got the idea. We're doing 4 or 6 teeth here. It was 4 teeth. So I don't need to be as specific with my shade taking. You can see the doctor used a 1M1 reference for the basic value. They also put a 1M2 in there because they're looking at the chroma that's coming through and they shot it a little darker. So I can start to see some of that chroma scope coming through. And I'm thinking, okay, well, what enamel do I want? I want something fairly transparent. So am I going to use 1M1 and 1M2? Probably not. It's going to be a refractory case. And I'm going to start by doing exactly all the things I said I would normally do. I'm going to raise the value in the center third of the tooth. I'm going to add some chromatide colors or absorbing material around the cervical. And then I'm going to start to transition to create somewhat of a more translucent looking incisal edge, but not necessarily an 80-year-old or 20-year-old, somewhat in the middle for our patient. At that point, I'm going to follow that with my dentin material. So I'm going to brighten up that middle third of my dentin, and then I'm going to start creating my canvas or my window with my translucent blue type materials. My mamelon materials will go over that. Those are my floating colors. And then at the end, I'm going to start covering that with my enamels. And the whole purpose here is now I wanted to use something very translucent to cover over what I built inside. That's what I saw in the patient. But even though it's translucent, I might use a translucent with a little bit of chroma in the cervical. I might use a translucent with a little more whiter or reflective area in the middle third. And then towards the incisal edge, I might use all of them. I might use a little value, a little transparent, a little color. I might use a little of all of them to make that effect look a little more natural across the teeth. So I'll start by putting that little bit of a white enamel in the center, building over that with some more translucent materials, and finalizing that as my filtration. So in the end, that enamel that I'm finishing with is really more of a translucent type material to cover the effects of how the light works and how I can make the light either absorb or reflect from the value that I've created inside the tooth. And you see when we go to place that in the patient's mouth, I like this shot because you can see how nice it kind of goes around the tissue and really kind of absorbs in there. And notice I'm look at her cuspid and look at my central. I have a fairly similar amount of translucency, not a ton. I have a similar kind of a value, maybe a hair brighter in the central. And we'll just place all 4 veneers. This is still the patient's numb, so Tissue hasn't healed in yet, and you kind of get the idea. But that's my way that I kind of go through the shade taking process. So Jim, I hope I fulfilled the task at hand that you asked me for, a simplified shade taking process. I don't know if it's simple. I don't think it is. I think it's really about the two key factors that I said before. Understand what you're looking for first, and you need some documentation to really kind of utilize that. And by the way, that documentation helps you more at the end when you learn to see what you did wrong, what you missed. It's priceless if you can really start to look at your work and say, that doesn't look right. What do I need to change? Do I need more of this or less of that? And how do I make this work in the shade taking process? So with that said, I think I'm on time, Jim. Yep, 12:55. I'll say thank you, and hopefully we have some questions out there. We have a lot of people in there today. I think I see 180 people. That's very nice. Thank you guys for joining, and it's always such an honor that so many people attend and pop into these. So thank you. And thank you, Jim.
Yes, thanks, Peter. No, you're perfect. You know, you tackle each topic, put everything into it, and I think you fully go through it step by step, which is excellent. And I think our audience is grateful that you take the time to do that, to educate them.
Thank you.
Before I get going, let me just go over a few things with everyone that they're asking about. So I'm just going to become the presenter, show my screen, get back to my presentation here. Let's see here. All right, so those of you that asked about CE, you'll receive something, a notification through the registration email that you provided us when you registered for the program. The workshop has been recorded. Visit us on the VITA Learning YouTube channel, VITA North America YouTube channel, or our other social media websites. You can look at that recording. If you do need to get hold of someone here, there's some information here that will guide you to whomever you want to maybe contact. Peter, on his last slide, he did indicate how to get a hold of him. We do have a help desk number. You can give us a call here or email us whenever you want. Peter's going to do a couple more this year, and then we've got him scheduled for live sessions. We're going to have him scheduled for some live in-person programs next year in 2023. But we do have quite a few things still on the books for the rest of this year. So please come back and join us for another webinar with Peter. This is Peter's additional information there. And with that said, I'm just going to go over a few of the questions that we do have so far. And one of them is going to be, we always get this when you show your refractory model. Which refractory material do you use, and what is the water-liquid ratio you use?
So unfortunately, GC has discontinued their Overvest, which is the one we used to use. And the material I'm using now is called Shera. It's from a German company, and I have it coming through a company in California, a friend of mine. I think it's a 50-50 water ratio, but I have to be honest, I'm not sure. I'll have to check with Abe because he's pouring all the refractories these days. But this Shera, I have to say, very nice. It's really devests like powder. It's very white and powdery, and it's really nice. I did change my technique slightly with it. With the GC material, I used to use a connector paste over the refractory dye and fire that, and then whenever I put whatever ceramic on it, it seemed like it worked very well. With the Shera, I found that the connector paste didn't work as well, and I've kind of gone backwards, and I'm just taking a transparent material from VM9 on the window as an example, doing a very, very thin wash and firing it just a few degrees higher, and then building all my ceramic on it. So I'm treating my wash a little bit differently with the Shera, but I have to be honest and tell you, the way it devests and breaks out, it's beautiful. It's like, it's almost like, you know, powder comes out of the thing, and it's no grinding. It's much nicer.
All right, thanks. Yeah, it's different. You know, a few years ago, there was many on the market. Now it's not as many. So question is, if I can't find an exact match with a tab, what do I use in the photo to recommend to the closest reference?
So you'll never find, yeah, you'll never find an exact match. You're always going to find a reference, and sometimes you may need more than one reference. So like the pictures that I showed of those teeth that had 6 different colors in them, maybe you need 5 shade references. Maybe you need the cervical of the 2M3 and the incisal of the 1M1. You might need a few different ones. The other thing that you could do too is with the ceramic system, and I probably should have showed this, I'm not sure why I didn't, but the actual shade tabs of the ceramics that you use are a really nice, useful tool. So your doctors may not have them. Maybe you want them to get them sometimes, but I can tell you if I'm struggling to look at what I see in the shade, I might take out the translucence of the VM9 kit or one of the actual guides of the kit and utilize that to help me see what the color is.
All right, thank you. So what is, Evan has a question. He was asking what the source is for the range of natural tooth color. And I think if you don't have that, Peter, he can email you. But if you don't have it, just let me know. I can, Evan. I can also send something.
What do you mean the source? I'm not sure what you mean.
You know the world, the color world, the sphere that has the colors.
Yes. Mm-hmm.
Yeah, if you have that as a reference, otherwise Evan can just email me and I can send that out to him.
Evan, we just made that up because we hate C and D shades. No, the truth of it is it's science, right? I mean, if you scientifically analyze the color scope, and if you understand that globe of color, to get to certain ranges of yellows or greens or blues, you have to travel around in that color world. And what we find is when you look at it scientifically and analyze the calculations of RGB and color scope, you start to notice that a lot of the shades that we use, especially in the old classic guide, just do not fit into the basic color scope of teeth.
So for many of you, if you know, Peter has graciously provided his email address. So if you want to email him, please do, and then loop back if you need additional support with us. Another question is, do I always ask my dentist for a polarized photo, or should I?
So I think the polarized photo is most important in single or two-tooth dentistry when you're really trying to match something specifically. Utilizing it more doesn't hurt because it just gives us more information. But honestly, once you get past 6 or 8 teeth, I'd say it's just a wasted photo, right? Because you're kind of creating your own at that point. So for me, it's most specific in the 1 or 2 kind of restorations. I guess I'll throw in there, Jim, that there was a nice learning curve to it, right? So anytime you can stare at teeth and see it in polarized, there is a nice learning curve there too.
No, it's a good idea. I mean, you know, if you can get what you can and see what it looks like at post-op, right? I mean, I think that's the best idea of knowing what you achieved and how well it blends in. You're right. What is your go-to, the big question, but what is your go-to milky incisal?
Probably, and this might sound funny, but probably straight ENL if I'm in VM9 or V13. And the reason I say that is because I don't really use ENL straight anymore. I tend to always mix my ENL with a little bit of window to get more of that translucent effect at the end. So when I want it to be more milky, I tend to use the ENL straight first, and then my mix of ENL and window over it. But if I'm really looking to push it, I would go with an effect pearl, like the effect pearl 1 or something even whiter and brighter. But it really depends on the brightness of the shade. But I guess I want to be clear that I'm not using the ENL probably straight the way everybody is anymore. I'm using it much more transparent by mixing it with a little bit of window.
All right. With so many porcelains, Brian has a question here. With so many porcelains in one crown, how many times do you end up baking it or firing it? And at which layers do you fire?
It's so many what with one crown?
Porcelains. So to someone,
okay.
others, it looks like a lot of porcelains, but you wait until the end and then you fire the whole thing. Do you fire intermediately?
Yeah,
and
yeah. So
how many times?
if I'm building a single unit, a single central, a single molar, a single bicuspid, any single tooth for me, I don't care if I use 15 or 30 powders. It's pretty much one bake. I'm pretty much doing that all in one bake. Do I need a correction? Sometimes I might need a little correction, and depending on how much I need, I'll do that at the end. Do I recommend that for everybody? No. You could multiple fire. You could build your opacious materials, your CPs and your ECs, and then some dentins and fire that first to evaluate your positioning, and then come back with all your enamels and translucents. For me, at this point, though, I feel like I tend to do that more in one bake. And even in larger cases, you know, if I have, I just finished a case now that's, I think 14 or 12 single units. I did the whole case in one bake, and then I came back and did a correction bake just to add, you know, little details and where I missed, because it's really just 14 single units, right? So I think the problem that I have with it, or I think most people have with it, it's really not the ability to do it. It's the ability to stay focused long enough to do it well. And I think that's where I struggle, right? Because I can tell you after 2 hours into a build-up, I'm like, you know, one side came great, the other side, I'm like, oh, I'm just getting this done. I can't pay attention anymore, kind of a thing. So for one unit, one bake should be what you need. But when it's in multiple cases, I don't have the brain power to make it go for, you know, 4 hours, keep building.
Very good. Can you tell me, this is a question from Nico, can you tell me, do you do much pressed ceramics for veneers? And do you have a preference pressing versus refractory for your veneers?
So Miko or Nico, that's a loaded question, because if you watched any of my previous webinars, you'll know that I'm predominantly a refractory guy. So I like refractory veneers better than anything else. I'm not a huge fan of lithium disilicate veneers. I think, without being insulting to people who do them all the time, I kind of call it the McDonald's of a restoration. Everybody's doing them very similar, very staining, and I don't think they have as great of an effect. And where I have shifted to be more digital or more current is with the Mark II, or I call it the Evolve material. The Mark II is a milled feldspathic veneer, where I can actually mill out the veneer, and I can either use it as a monolithic or micro layered on top. And it's much more aesthetic in my mind than lithium disilicates. I'm not knocking people who do the lithium disilicate veneers. We do some too every now and then for certain cases. But in the end, the most aesthetic for me, I would say, is refractory and anything feldspathic. So that's refractory and Mark IIs. And then after that, it's secondary aesthetics to me, and it doesn't mean I don't do them. I have a lithium disilicate case on my desk now that I'm micro layering on, but my first choice, refractory or Mark II, Evolve.
All right, I like that. On bleaching, a couple of questions. One is, how long do you wait to take a shade after the bleaching has concluded with that patient?
At least 2 weeks.
Probably depends.
At least 2.
Okay. And then what do you use to hydrate the tooth prior to taking a shade?
I don't. The patient's tooth is naturally hydrated unless they've been in the chair with their head back and mouth open for a long period of time, or unless they're on some sort of medications. Sometimes medications affect the hydration level of the tooth. and you don't know that or you can't control it. So it's a little challenging for you. The only way you really control the hydration is don't let them be anesthetized, or don't let them be with their mouth open getting work done for 4 hours before you take the photographs.
All right. Mohammed has a question. Which shade guide do you use to measure dark staining, like the ones you would have for a patient with fluorescence before bleaching?
Which shade guide is to measure dark staining? So I don't really measure
Yeah.
dark staining. So I think, I mean, well, could I use the shade guides from my stain kits? I could. But I have to be honest and tell you, I probably never do. And the reason I never do is because if I'm matching an A4 tooth with a lot of dark staining, well, I'm using that A4 or I'm using that 5M2, and then the coloration that I'm using is usually in the brown or orange or mixed family, right? So once you're in that world, I don't know if I need to really measure the staining itself. Although if you wanted to, I would say then you go right to the stain. So every staining system has a shade guide with it, right? And you can actually see all the colorations that are there.
Mohammed had a follow-up. Would it be possible to use that spectrophotometer, the VITA Easy Shade, for that dark tooth?
I don't know the right answer for that, Mohammed. I would say probably not, because for one, if it's at the cervical or at the proximal, it's a little hard to get the easy shade, the angulations that you need. And two, I would also argue that staining is usually on the surface of the tooth. It's not inside the tooth. So because it's more surface oriented, it's blocking the light from actually penetrating into the tooth. And I would imagine, and I haven't done it, but I would imagine the coloration representation that it's giving you is skewed because of the masking of the material.
All right, and then kind of last question, if any more come in. Back to the veneers, refractory veneers. They're asking, do you provide warranties on your work?
Do I provide what?
Warranties. Your guarantee. Do you do a guarantee, a warranty?
Yeah, I guarantee you I'll be here if you call me after something goes wrong with the case. But that's about it. No, I think that's really silly. And I'm sorry if some of you do that. I don't mean to be. Look, teeth break. All of them break. Natural teeth, fake teeth, 8 billion thousand megapascal teeth, all of them can do something that is wrong. The concept of warranting something, I think it's just kind of silly. And it sounds, I don't want to say cheap, because I think that doesn't sound right, but I guess that's the only word that I think of. It sounds a little cheap, like, you know, we stand behind it. I stand behind everything I do, but I also realize that things can break. And I think it's really more about a relationship with the doctors and the people you work with about how you work through that. I would also make the discussion for this, just to be clear, I would rather see a minimally invasive case done on a patient where we save tooth structure and see my veneer break 2, 3, 5 years from now, and me make another one, than me to use a big full coverage preparation with an 8 billion megapascal restoration, and then the failure mode is in the tooth breaking, right? So that concept, I think, that the profession teaches us, I kind of disagree with. Materials can break, teeth can break, things can go wrong. We should balance them the best we can, but I don't know, you tell me the liver doctor that does the liver transplant and gives you a guarantee when you're done. I don't think it exists.
Yeah, that's a good analogy. So, thanks, Peter. And that pretty much wraps it up for today with the questions. So, any last words, Peter, that you'd like to say today before we let everyone go?
You know, listen, I hope I don't sound harsh when I'm giving some of those answers. I'm just trying to tell you the truth kind of quickly. I get it. If you're building your business and you're trying to work through things and you want your customers to be faithful to you, I get it. I've been there, and I work at that every day to make my customers feel comfortable. But I think you also build your customers and your value and all those things from learning the things that we're talking about today and applying them in your business. And I think that's really where the key is. And I guess I'll just end, Jim, by saying, you know, patients that come to us that have spent 50 years making their mouths look like what they look like and expect us to fix it in 2 weeks and have it never break again doesn't sound like a fair equation or a fair example of how that works. So we need time, we need understanding, and we need to accept that just because it's 8 billion megapascals doesn't mean that it's the right material for every case either. So that's just my my take on how I try to do it.
No, well said. That's very good. So thank you again, Peter, for your time and graciousness to provide the excellent education to everybody. I think it was excellent, not because I made it, but I think it was an excellent topic. A lot of questions swirl around the shade and the approach and so forth. And I think you put it into a nice, succinct manner that we can all understand. So again, thank you, Peter. I would like to also thank everybody for joining us today. And I will go ahead and conclude today's webinar. So thank you again for everyone for joining us, and thank you again, Peter, for taking the time out of your day.
Thank you guys all for attending. I really appreciate it.
Thanks. This concludes today's webinar.
Take care.